Hi. So I've got 15 minutes to talk to you about how we're going to journey towards a new gold standard in the colorectal cancer diagnostic pathway. So let's start. So the poet Wilfred Owen used the term obscene as cancer to try and get people to see the horrors that he'd seen in the World War I battlefields. And that resonates with the emotional feelings that the word cancer brings out in most humans. My area of interest is colorectal cancer. And every year, globally, we see over 2 million new cases of colorectal cancer, 42,000 in the UK and 350 in my hospital alone. Now, these are big numbers, but they're abstract. What isn't abstract is the number 1 in 17. And what that tells us is that one person in every row in this lecture theatre right now will suffer a colorectal cancer at some point in their lifetime. In fact, in all likelihood, somebody in this room has colorectal cancer right now, but they don't know it. The good news is that for most cases, colorectal cancer is treatable. And in common with lots of different cancers, if we catch it early enough and act quickly enough, we can even talk about a cure. This is the reasoning behind the National Faster Diagnosis Standard, and that challenges us to move towards a diagnosis or a discharge from the pathway of patients within 28 days of their referral. Now, up and down the country, trusts have created pathways to try and meet that challenge. So in my hospital, this is the colorectal cancer, suspected cancer pathway that we've been using for the last few years. On the left of the slide, you can see the patient journey, and unfortunately, what that involves is a lot of waiting and worrying about symptoms, waiting to see your GP, worrying about your appointment with the specialist, waiting for your investigation, worrying while the result comes back. The GPs do an awful lot of work before they refer us the patients to make sure we're seeing the right patients. But in my hospital, we get between 500 and 600 referrals every single month with suspected colorectal cancer. And so every orange square that you can see here has to be created 500 or 600 times every month. It starts with a triage by a colorectal nurse specialist, and then some patients go straight for a test. Some patients have a telephone consultation with a specialist nurse or with a doctor. Some patients have a face-to-face appointment with a nurse or with a doctor, and then they're sent for an investigation. The investigation is then sent back to a named responsible consultant and waits until the consultant writes back to the patient and tells them what the next step is. Up and down the country, we're failing. We looked at our figures recently and found that we're meeting this standard in under 50% of cases, and that on average, patients are waiting 28 days before they actually get to their diagnostic test. So what is that test? Well, for most people, it's a colonoscopy. So about 3 years ago, I had emergency surgery for an appendicitis. Embarrassingly, it was diagnosed by my 12-year-old daughter at the breakfast table. The next morning, my colleague came up to me and explained that, yes, my appendix was a bit manky and they'd removed it. But actually, there was a bit of my bowel that didn't look quite right. Two of my colleagues looked at it carefully and they decided to give me the benefit of the doubt, so they didn't remove the bowel there and then, but in 6 weeks' time I would need to have a colonoscopy. Now that was a humbling experience. I've been referring patients for colonoscopy for over 25 years now. But what I realised is it's not about the mechanics of having the test. The patient experience starts the moment that someone tells you you need to have a colonoscopy, and it starts with that waiting and worrying. Not all-consuming worrying that's there in your mind all the time, but little thoughts that jump into your mind, little questions. Questions like, I wonder if there's anything wrong. Questions like, do I have cancer? Questions like, will I see my kids grow up? And then comes bowel prep. Now, we tell patients bowel prep is special medication to flush your bowels out so we can get a clear view. But it's a little bit more than that, really. If you Google the words Billy Connolly colonoscopy, one of the first things that comes up is a link. And he describes in great detail his experience of having bowel prep and then a colonoscopy. Now, I can't recreate his colourful description, obviously. But what I will say is that I had an evening where I spent very little time enjoying the comfort of a silent night mattress and quite a lot of time testing the flushing mechanism on the Armitage shanks. When morning comes, the effects are still evident, and you wait for some sort of continent window of opportunity so that you can be driven to the hospital, hoping not to leave some long-term evidence on the upholstery in the passenger seat. When you get to the hospital, you're presented with dignity pants. These are a one size that really fits nobody garment with a big hole at the back to accommodate the educated finger in your bum, which is then replaced by something which is about the same width, but 2 meters long. This thing then wriggles around inside you for the next half hour or so, while the endoscopist negotiates the twists and turns of your intestines. Now, the outcome of this can be categorised according to a traffic light system. I was fortunate in that I was green, which is either normal or a very minor abnormality which requires no further follow-up. Amber is a benign pathology which can be managed according to national guidance, and then red is obviously a cancer. So what do those numbers look like? Well, we need to do 25 colonoscopies to find one cancer. For every 100, we find about 4 cancers in our hospital, and about 12 people have a significant benign pathology, but 80 to 85% of patients have essentially nothing wrong with their bowel. We see 100 patients every 6 days. That's what 500 a month looks like. And every year, over 5,000 patients are discharged from our colorectal pathway in our hospital. That's 5,000 essentially normal colonoscopies, some of which will have complications. Our local health economy spends between 3 and 5 million getting to this point on the colorectal pathway, and nationally we spend about £1 billion up to this point on the colorectal pathway alone. We spend more generating normal clinical results than we spend on the entire treatment costs of all the patients diagnosed with colorectal cancer on that same pathway. And that alone is enough to make us pause for thought. So what's wrong with this experience? Well, it's awful. We're doing different things for different patients who are waiting and worrying. They're competing in acute hospital with patients undergoing emergency care. They sometimes get sent for the wrong test. It costs a lot of taxpayer money. For the staff, it's demoralising. We're not able to give the service that we want to be able to give, and it does our trust, reputation and financial damage when we miss our targets. So FIT has been introduced to try and reduce this problem, but with the mitigations for the sensitivity and specificity of FIT, we haven't seen a big drop-off in the number of referrals. So most patients still need to have an appointment with a senior clinician, most patients still need a colonoscopy, and it still costs vast amounts of money. The system struggles to cope. And patients who are not on this pathway get pushed aside and can wait over a year to be seen. So with the TRIOMIC study, we have the opportunity to improve both the pathway and to think about a new test. So with the pathway, the first thing that we're going to do is move the assessments, the outpatient assessments, out of the acute hospitals so that patients are not competing with the emergency patients, with the ambulances queuing outside the hospital. We've worked with our local care board, and we've got clinical space in a community diagnostic centre, which is an entirely elective hub. We've already started running clinics where patients are seen by senior nurse specialists, and we've made 5 appointments to these clinical nurse specialist roles so that over the coming months we will be able to offer up to 600 new patient appointments every month on this pathway. The patients will have a detailed assessment and get sent for the right test. The test will then go directly back to the clinical diagnostic centre, and our ambition is to turn round and achieve the faster diagnosis standard by day 13 in 90% of our patients. That is a vast improvement on what we're doing now. It's better for our patients, it's better for our staff, it's better for our department. But we are still in the situation where every month we have over 500 patients and we don't know who has a condition which needs treating. So these patients still have to get sent for their colonoscopy so we can identify the pathology and give the right treatment to the right patient. And this is what we're doing to overcome that. So every patient who attends the clinical diagnostic centre will be invited to give an oracle sample. Now the science. So we know when we look down a colonoscope that cancer looks different. We know that you don't just suddenly get a cancer, but there are pre-malignant areas which also look different, including polyps. We've known for decades that those macroscopic differences are mirrored with subcellular abnormalities. Abnormalities in terms of genetic mutations, abnormalities in terms of epigenetic phenomenon such as methylation, and even changes in the microbiome, the type of bacteria which are found in the bowel in and around cancers and precancerous polyps. We know that the colon is coated with mucus and that in normal health, as the bowel lining is regenerated, the normal cells pass through the mucus into the rectum and are flushed down the toilet in the normal manner. We know that if you've got abnormal cells from cancers and worrying polyps, they travel in the mucosa and they are lost in the same way. And as Hugo has demonstrated, we have a simple, safe, and quick test which can be done on any patient in any outpatient clinic, and we can collect a sample of that mucus. That sample can then be sent off, and there is now the technology available so that we can measure the genetic abnormalities, we can measure the epigenetic methylation, and we can look at the microbiome changes. If in doing that we can find a fingerprint which identifies those cancer cells, which identifies those pre-malignant polyps, then we would truly move to a new gold standard. We would be able to change colonoscopy from being a maximally invasive investigation, which nearly everybody has to have, to being a comparatively minimally invasive part of a treatment pathway, which those at greatest need will have easier and quicker access to. That would be a new gold standard that the entire world would wish to adopt. The difficulty is the NHS can't do it on our own. We need access to people who have logistical measures in place so that they can ship the samples to laboratories that have access, easy access to high volumes of cutting-edge technology so that they can measure the genetic mutations, the epigenetic methylation, and the microbiomal changes. And that's why we need to collaborate with industry. And that is, of course, what today is about. And that's what the rest of this afternoon's talks will be on.
So I want to make just two thank yous, really. Firstly, to Hugo and his team, Ian, Daniel, Archie's over there, who I think have put on to a really remarkable event today. I think for a small company to get this kind of collaboration from so many companies, whether it's as big a company as IBM or some of the smaller companies, is truly remarkable. And if we can deliver a colorectal cancer diagnostic, and maybe in time a screening test as well, which is easily accessible and which has the kind of specificity and sensitivity that Daniel mentioned in his talk, 97% sensitivity, I think, and 95% specificity, because we've got to have a small number of false positives. If you've got a lot of false positives, it kills it from a health system's point of view. And if the sensitivity is not there, it sort of kills it from the patient's point of view. So you've got to have both. It's invidious, I think, to pick out any one other person for thanks, but I am going to pick out one other person, who's John Lacy-Colson, sitting here on my right, from Shrewsbury and Telford. And I want to pick him out because I know how hard it is to drive innovation and a change in the patient pathway in particular within the NHS. It is incredibly difficult to take on all those vast battalions who have an incentive not to change. So I think to have got this through Shrewsbury and Telford, through the CDC, the Diagnostic and Treatment Centre, there is a phenomenal achievement. If we can now then push that out through Manchester and other parts of the NHS as well, it will be a fantastic, fantastic progress. So on behalf of everybody here, I think, thank you, Hugo, for putting this on, and thanks to Origin for bringing everyone together. Thank you very much.